Hi, it's Dr. Centeno, focusing today on knee osteoarthritis or knee arthritis. So we'll get started here and focus again today is on knee arthritis or knee osteoarthritis. So first, a disclaimer. Some of the things I'll be talking about here involve some cultured stem cells, and that can only be done outside of the U.S. at the independently owned Grand Cayman site that we work with, but most of it that I'll be talking about today won't involve that. So in 2005, we were the first clinic on earth to really begin treating orthopedic conditions, injecting into joints, low back discs, and tendons. And our focus was using stem cells to try to treat those issues and help patients avoid surgery. And back then, there was really no one else on earth doing this kind of work. There was one gentleman in Paris, France, Philippe Hernegal, who was doing some similar things using bone marrow concentrate, mostly injecting into bone. But his focus really wasn't doing these other things. So there really wasn't any textbook that we could go to figure out how to do this stuff. We literally had to create an entire medical specialty. So what is Regenexx? We're an exclusive network. We're international. We've got most of our concentration in the US, but we've got quite a few sites outside the US. Coming soon will be a site in China as well. And we focus on getting the top experts in interventional work, meaning doctors that know how to place things in specific areas of the musculoskeletal system using imaging guidance. And you can't just join Regenexx. If you're a family doctor and wherever, we're probably going to turn you down for inclusion in this network because you probably don't have the basic skill set to do this work. So what isn't Regenexx? This is not a doctor who buys a simple bedside centrifuge and took a weekend course on injecting stem cells. This isn't a surgeon that throws in some PRP with his procedures to kind of give some magic pixie dust. And we're not chiropractors, naturopaths, or acupuncturists offering to inject dead stem cells, and I'll talk to you about that a little bit later. So we're very different, highly trained specialist physicians. All injections are performed with imaging guidance. We process your cells in a custom flexible lab platform that each clinic has, sort of a mini lab, and not a simple bedside machine. We've got a multi-million-dollar research facility backing up what we do, extensive training programs for our physicians, and we've got obviously quite a few US and international sites. So let's just give you some examples of what we're talking about here today. So interventional orthobiologics basically means that there are injectates or things you can inject that will help to heal bone, tendon, ligament, muscle, or cartilage. And we use precise imaging guidance to get those into specific areas. And then there are constantly being developed new tools to expand that scope. What I mean by that is to allow us to do more things to help patients avoid surgery. So I'm a real graphical kind of person, so I always try to put it in graphical terms. So, most physicians, if they're going to do something like this, will just inject some stuff somewhere in the vicinity of the joint. Sometimes that's blind. Sometimes they've got some simple imaging guidance. But that's not what I'm talking about. What I'm talking about really is a different world, and that is very precise injections into specific damaged structures. So, for instance, inside the femur bone, in an area where the bone's breaking down, or into the patellar tendon of a knee, or the ACL, or the meniscus, lots of different areas that can be targeted. And obviously, the first part of that is you got to know what's wrong with the patient. And that's not trivial. So here's an example of what I'm talking about. You can see here that this is a knee MRI, and we're looking at someone's kneecap here, and it's sitting in the groove. Now, this bright stuff here means that the bone in the kneecap itself is starting to break down. It's not doing well. There's also cartilage damage here. So most people would just inject somewhere in the vicinity of the knee joint, but here we're using serum fluoroscopy to not only with this little needle inject stem cells right where there's a problem in the cartilage, but also where there's a problem in the bone. So this is a mini trocar injecting into the bone and injecting into the cartilage. That's interventional orthobiologics, very different than just going to a chiropractic office and having a nurse slam these things someplace into the knee joint. Now, why will all of that stuff likely replace much of elective orthopedic surgery? Well, it's less invasive, much quicker recovery, and you can preserve the normal biomechanics. So the problem with surgery is we frequently take stuff out, and by taking stuff out, we're destroying how things work. And what we're not talking about, and again, I'll talk more about this later and elaborate more, but we're not talking about magic stem cells here. We're really talking about lots of different procedures that we perform. And for example, we will often use things like platelet-rich plasma because probably 60% of our patients will respond with that. It's cheaper, it's less invasive, and it works for the right patients. Now that's very different than a clinic, chiropractic clinic that just does stem cells and wants to maximize every dollar out of every patient. This stuff's a lot cheaper than getting, quote, umbilical cord stem cells, and we'll talk about those. But it works in a lot of people, and I always tell patients it's my job to find the least invasive, least expensive thing that's the most likely to work. And then we'll do same-day stem cell procedures in some of our patients that need them. We'll add in some ECM products sometimes when we need those. And then we've got the ability to do culture-expanded stem cells down at that Grand Cayman site if we need that. But those patients are more rare that require that type of technology. And we perform lots of different treatments on lots of different areas, but today we're going to focus on knee arthritis. So very, very specific focus here. So what is knee arthritis? It's loss of cartilage, bone spurs, meniscus tears, loose ligaments, irritated tendons. You can see the picture off on the right there between those two pictures, and you can see damage in the cartilage. You also start to develop bone spurs. The meniscus can develop problems or had problems before. The ligaments can get loose, so the joint gets sloppy, and then the tendons can get irritated, and that's called tendinopathy. And all of that can be part of knee arthritis. So our treatment approach is to first identify the various issues that are having problems. And again, that's not trivial. That takes being able to read the MRI yourself. It takes a really good exam to figure out where to place these cells. And as I said, just placing them somewhere in the vicinity of the joint, which is what most clinics do, generally is shortchanging the patient and not maximizing the outcome from the procedure. The problem is it takes longer to identify where this stuff needs to go. Then we use imaging guidance to get it to those areas. And then we match the specific orthobiologic to the patient. So I already talked a little bit about that, right? We had PRP. And if someone's got mild knee arthritis, PRP works great. There's no reason to use stem cells in that patient. So that's matching the problem to the orthobiologic we're using. So identifying treatment targets. Again, most stem cells just kind of throw stuff into the joint. We don't. The problem is that many times those cells will never get into the specific damaged structures where they need to go. So we are targeting, for instance, ligaments on X-ray guidance or ultrasound, or tendons on ultrasound, or injecting into specific parts of the bone with X-ray guidance, or meniscus, or various specific parts of the joint. And as I said before, we match the orthobiologics to the patients. The guy on the left is, the kind of the classic thing you see, kid wearing a suit that's too big. The guy on the right's got a tailored suit. Our focus is to try to tailor the orthobiologic to your problem. So, for instance, as I said, PRP works great for mild arthritis. There's no reason to use anything else. It's cheaper, it's less invasive. So we'll do that rather than pushing someone into an expensive stem cell procedure they don't need. Having said that, if you've got more severe arthritis, you need that stem cell procedure because PRP is not going to get it done. We use advanced imaging guidance, so that's generally fluoroscopy and ultrasound. We don't allow nurses to do this work at all. We don't allow a physician assistant to do this work. No mid-level providers. We don't allow general family doctors to do this work. You will have a specialist physician that knows what to do. And so these are the three types of knee arthritis that we'll cover today. One is a chondral or osteochondral defect or a pothole in the cartilage, bone-on-bone arthritis, and meniscus problems. So pothole in the cartilage basically is what this is. We've got fancy names in medicine for these, but a chondral defect just means a pothole or a hole in the cartilage that doesn't involve the bone. Osteochondral defect means a pothole in the cartilage and the bone. So that's just kind of like a deeper pothole. And what's interesting about these types of problems is many patients will end up getting ACI surgeries, microfracture, MACI surgeries. But these types of problems do respond well to these sorts of orthobiologics. So many of these lesions will heal over or get better if you use a very specific approach of placing stem cells right at that spot. So these are some of the examples that we've seen through the years. On top there, the red arrow is pointing to a hole in the cartilage or a chondral defect. And the after MRI image before, you can see that that hole or the dark area in that lighter cartilage has gotten smaller. So that's the yellow arrows. Again, up top here, this is another chondral defect that goes all the way through to the bone. And that's that area right in here as shown by that red arrow. So basically that's kind of a fissure or a narrow loss of cartilage in that area. And on the after images, we don't see that. So we've seen that time and time again, that proper stem cell treatment can generally help to heal things like this. Doesn't mean it's going to happen all the time, but it's certainly a heck of a lot invasive than a surgery. However, now we're going to move to another big problem patients have, and that is kind of bone-on-bone arthritis, or something that requires a knee replacement. So the patients, most common patient is usually someone in their 40s or 50s or older, and they've gone to an orthopedic surgeon. That surgeon has said you need a knee replacement. Either you're too young or just come back when you can't stand it anymore and I'll cut out the knee and we'll put a prosthesis in there. So instead of that joint amputation with an insertion of a prosthesis, which is what this type of surgery is, we inject high-dose bone marrow stem cells in a same-day procedure precisely into the knee where those cells need to go. Again, identifying all those targets I talked about. So from a 30,000-foot view, we are able to help these patients. Now, the problem is that we're not regrowing you a new knee. And I'll show you some scam stuff that's out there where they show you an x-ray that seems to show that the joint space width gets bigger with magic umbilical cord stem cells. Doesn't really happen. We're not doing that either. These patients are far better, and they're far better by replacing the lost stem cell reserve within the knee and helping that toxic environment and cleaning that up within the knee. But we're not regrowing them new cartilage. They do go back to what they want to do, but they still have that bone-on-bone type presentation in their knee, and nothing out there is going to change that. But functionally, they're doing quite well. So this is some MRI changes that we do see, and what basically this shows here is in these 2012 images, a lot more of this white stuff in the bone. That's called the bone marrow lesion. In the 2018 images, a lot less of that. So that's all good. That means these are the kinds of MRI changes we can see in these patients, because if we look at what's symptomatic on knee MRI in patients that have bone-on-bone arthritis, it's really these bright spots in the bone. Those are called BMLs, or bone marrow lesions. And we can generally help to get rid of those, which is great. It's probably another reason why a lot of these patients become asymptomatic, because those are the most symptomatic areas. We think that it's the knee that's causing a lot of this pain, but it's usually the bone that's causing a lot of this pain. So this is a guy, very nice to get these things from patients. This was my partner, Dr. Schultz's patient. He happened to snap this pic. And, as he said here, 2 ortho doctors said I needed to replace both knees. He is from Seattle. He had traveled here to Colorado. We now have a provider in Seattle. And obviously he did very, very well. He's out riding his bike 6 years later. So we've published research in this area. And again, realize that we're one of the few folks out there that are actually publishing research on this stuff and what we do. We also have a randomized controlled trial, and that's right here. So this was published in 2018. It was a physical therapy group versus a knee stem cell group. These were patients who were candidates for total knee replacement. And basically what all these charts show is that we did quite well against physical therapy. Why did we choose this study design? Because this is the same exact study design from the only randomized controlled trial for knee replacement that exists. So we just replicated it. And now we have 2 new studies that really take this out much further. And these studies are not published by our group, but by a gentleman that we've worked with, Philippe Hernigau, in Paris, France, and basically showing amazing 15-year results. So basically only 1.3% of the patients that he treated need a knee replacement per year. So by about 15 years, about 1 in 5 had progressed to a knee replacement. So pretty amazing results when using the same type of technique that we use every day in the clinic. So meniscus tears. Meniscus tears are super common in people who have knee arthritis. And we've got a procedure for that as well. So basically the meniscus is that cushion, kind of a figure 8 type thing here in the middle, and it cushions the femur or the leg bone against the thigh bone. So the femur, thigh bone, and the tibia leg bone. And what's interesting is that an awful lot of older people end up getting meniscus surgery, and very few of those get a meniscus repair. What they really get is partial meniscectomy. So that means that the doctor goes in and trims out the torn piece. The problem with that is that the research has shown it doesn't work. So basically, the research shows the procedure is ineffective, but we also now know that these degenerative meniscus tears in older people are really like wrinkles on your face with age. We all get wrinkles as we age. There's no escaping it. And the same thing, we all get meniscus tears, or most of us will, in our knees as we age, and these generally don't cause pain. So we have the problem of someone getting an MRI who has knee pain, and there happens to be a meniscus tear, which they had before the pain, and the meniscus tear gets blamed on why their knee hurts, and then someone does surgery taking out that torn piece. And again, we now know through multiple large randomized controlled trials as of 2016 that these surgeries are not effective. So here's 3 high-level studies showing that meniscus surgery does not work in any clinical indication. And on the other hand, we do have a randomized controlled trial showing that injecting PRP into these meniscus tears can be effective. And this just shows you real quick here. I may not be able to start this video in this environment, so I apologize. We'll just move on from that one. So this is a younger patient that we treated who would have gotten a meniscus repair, and her father was a physical therapist. She had a meniscus tear. That meniscus tear needed to be treated. We treated it instead with PRP. She did very, very well. No surgeries here. Went back to, obviously, elite play. These are some MRI results that we obtained early on. We've also published on other MRI results. So this is a patient who, right before the procedure in 2008, had these light areas in the meniscus. So this triangle is the meniscus here. And then those turn into these dark areas. Dark is good, light is bad. Dark means a meniscus that's holding together. Light means a meniscus that's torn. And I want to kind of finish this up and talking about some crazy hype stuff that's happening out there. Again, as one of the founders of this field, it's really disturbing to see patients getting scammed. And frankly, there's more scam care out there than there is good care. And I want to make sure you understand that we've got a great network of providers that I stand by. Having said that, there are other people not in our network who I would send my mother to because I know they do good work. The problem is that that's a little bit like finding a needle in a haystack. I know who they are, but you've got no way to figure that out. And regrettably, 90% of the folks who say they can do this work are more in the scam crowd than they are in the high quality crowd. So when a new procedure comes out, at first it's magic and we doctors believe it helps everybody. And then you get to the point where you're like, well, this is great, but it's not helping everybody. It's helping a lot of people. And then you get to the point of figuring out who's a good candidate and who's a bad candidate. So we're in that third phase. We've been there for a while. Everyone else is still in the this is magic, it helps everybody phase. And that's one of the problems we see out there is that if your credit card clears, you're a candidate. For us, you've got to have specific things to be a candidate. And as the inventors of these procedures, we see amniotic and other umbilical cord stem cell procedures being offered to patients. And, you know, when we first went ahead and tried to look at this stuff, which we did many years ago, I was actually approached by a sales rep who claimed to have stem cells in a vial. And he wanted to sell me these. And I said, listen, you know, no offense, but I don't trust any sales rep trying to sell me anything. We have a university equipped lab here on site. So I'm going to test this stuff. And actually that was BioD Restore, as you can see there in the poster, to see if it has any stem cells. And all the cells were dead. And then we tested some more and all the cells were dead. We tested more. And then the lab at UC Davis tested some stuff. And then the lab at CSU tested some stuff. Then the lab at Cornell tested some stuff. And it was all dead tissue with no viable cells, let alone stem cells. And what's really interesting is there's a lot of folks out there who will claim that you're too old to use your stem cells. Now, our data has never shown that in knee arthritis. And if you look at this, this is a test looking to try to see how many stem cells, what the density of stem cells is in the product that we're testing. So off on the left there, you can see a number of, or 5 stem cell products. The all white in those umbilical cord products means that there's no stem cell content whatsoever, or at least mesenchymal stem cells. The purple dots off to the right here clearly shows quite a few stem cells, and that's from bone marrow from a 56-year-old, 73-year-old, 55, and 64-year-old. So obviously, lots of stem cells in the bone marrow of elderly patients, no stem cells in the umbilical cord products that are used by these clinics. So how do they work? They're growth factor shots, kind of like PRP, but it's a super duper expensive way to do that and get growth factors, because you can get that stuff from your own blood. And calling this stuff stem cell shots is just consumer fraud. And again, there's no truth to the concept that you're too old to use your own stem cells at all. Another thing to be very aware of in the knee osteoarthritis world is what I call the scam X-ray evidence. So this is actually my knee, and what I did here is I took an X-ray of my knee using the C-arm, and I just tilted it. So this is what my knee really looks like, and you can see the joint space width here. I've got pretty good cartilage still left, not so bad for an old guy. But when I tilted the beam a little bit, all of a sudden it looks like I have no cartilage. So if I had started with a tilted beam X-ray of my knee, I could make it look like I had no cartilage. And if I was a doctor, I could convince a patient that this needed to be treated. Now, if I take another X-ray and I tilt the beam so it's going down the joint better, I could make it look like that I created cartilage. So that's what we're seeing when you see these before and after X-rays. They're just tilting the beam to get it to look down the joint better in order to make it look like there's been some cartilage created, but none has been created. And then we've got exosomes, another super popular thing right now. I mean, this is a little bizarre because we have zero evidence that exosomes will do anything for your knee. But this stuff is being sold, so doctors are using it. And there's this concept that somehow exosomes are better than stem cells. So exosomes are how one cell communicates with another cell. And it's a little bit like language or missiles that go from one cell to another cell, telling the other cell what to do. Now, that language between cells is context specific. So that means that that signal might say, become a cancer cell. That signal might say, get lost. That signal might say, I need you to repair something. That signal can say anything. And until we can dial in what those exosomes are and what they do, which we do not know yet, just taking garden variety exosomes and throwing them in is like creating missiles without guidance systems, or even payloads. So we've got to be very, very careful with this concept of exosomes. This could be very exciting one day, but what's being sold out there right now is not a dialed in message, for instance, for cartilage repair or for tendon repair or for bone repair. It's just a bunch of mishmash of signals, and no one has any clinical data showing that this stuff works. In addition, the FDA considers it an unapproved drug product right now. So that's a whole other set of issues with these companies getting FDA warning letters that make these, and the clinics that use these getting FDA warning letters as well. And then finally, we have the Regenexx corporate program, which has millions of covered employees who have full benefits for what we do. That's about 7 to 8 million covered lives right now. These are some of the companies off to the left. We have many, many more. And what that generally means is that if you work for one of these companies, Regenexx has full coverage. Now, that's still a fraction, a small fraction. We don't have Medicare coverage. We don't have United Healthcare coverage or Cigna or any of that. But if you work for one of these companies, you're covered. And you have to ask yourself, why are these companies doing this only with Regenexx? They're not doing it with anybody else, because we're the only ones that have this stuff dialed in to this degree that they're willing to take a chance on this and see if it saves them money. And we can save them money based on the data we've collected. So thanks for watching. So have a great day, and I really appreciate your time.